And now we'll shift to Dr. Akl Fahed. Dr. Akl Fahed is an interventional cardiologist at MGH, and he continued his fellowship at Harvard Medical School. He present to us the newest recommendation for polygenic risk assessment. So we can start with Dr. Akl Fahed. Thank you.
Good morning, everyone. Can everyone hear me?
Maybe we can increase the volume of the sound.
Let's give it a try.
Yes, that's good.
That's better.
Yes, that's great.
Perfect. I think you might need to mute the microphone because I hear an echo sound, I think. But I'll get started if people can hear me. Perfect. Well, thanks everyone for allowing me to just share with you some of our work on polygenic risk scores. And it's quite wonderful actually to follow Dr. Al-Naout with this deep dive into the guidelines. So this will follow very naturally from that. We're going to be talking about one small item in the guidelines, polygenic risk score. But it's important because it's new. For the first time, it's actually showing up in the guidelines. And this is where it shows up. It shows up in this table 13. Dr. Al-Naout just mentioned it, where we talk about the risk enhancers. And one of the risk enhancers is now formally recognized as high polygenic risk. This is very new. Many clinicians all over the world don't know what to do with it or how to measure it and what is even polygenic risk. And there's a synopsis table here, which is one paragraph in this section that actually explains how this came along. And I would say this synopsis kind of summarizes work of 10 years. Most of this work comes from our group at Mass General and Harvard Medical School. So I'll share a little bit with you the journey that led to high polygenic risk coming into the guidelines. And then I'll share with you also what's coming next, what to expect in the next iteration of the guidelines. The other thing worth mentioning here is that this is not the first time that the AHA-ACC recognized polygenic risk scores. There was previously a scientific statement specifically on polygenic scores if people would like to read more on that subject. But I want to start with a little bit with a patient story. This is a 38-year-old man who presented with a premature heart attack. I am sure many of you have seen patients like this one. This was an actual patient of mine from about 7 years ago, came in with an inferior STEMI in the middle of the night. He was only 38. And the interesting thing about him, when I was rounding on him the next morning, he asked, why did I have a heart attack? And we went through all the risk factors. He had none. All his numbers actually looked quite great. He looked as healthy as he could be. And then in these cases, this is when we think a lot about genomic risk. And then when we think about genomic risk, we think about three categories of genomic risk. I think many of us are familiar with monogenic risk. This is what familial hypercholesterolemia is, where there's a single mutation that actually drives increased LDL cholesterol and runs in families. But many of us are not comfortable with polygenic risk or even somatic risk. And we won't talk a lot about somatic risk, but we'll go deeper on polygenic risk because this is the subject of the guidelines. When we think about monogenic risk and polygenic risk, we think about them in kind of two categories. Again, monogenic risk is a single gene defect. So you have a single mutation in your DNA that increases LDL cholesterol. But polygenic risk is about a cumulative effect of many genetic variations across your genome. And we'll go a little bit into how this is calculated. But one thing to remember here that's important is the population impact is very large. For every 100 people who have a premature myocardial infarction, 2 have a monogenic cause, familial hypercholesterolemia, and 20 have a high polygenic risk. So this affects roughly about 20% of that population. So very, very, very common. Let's go a little bit of what is a polygenic score, so everyone understands what that is. And it's a little bit complex because it's not like a lipid that you just measure. It's a computational calculation using someone's DNA. And the way we develop that in simple terms is we look at hundreds of thousands of people with disease and hundreds of thousands of people without disease. So in this case, we're looking at people on the right with disease, coronary disease, and on the left, people without coronary disease. And then what you're looking here at the colors, every one of us will have genetic variations, so single loci in our DNA that either will increase our risk, these are shown in red, or reduce our risk, these are shown in green. or gray. They don't increase or decrease the risk. Now, you can see already that the people on the right side of the screen here have more red than green. So these people have more variants in their DNA that increase their risk. And what we do with the polygenic score is we add up, we sum the risk for a single individual, the risk increasing variants, the red ones, and the risk decreasing variants. And then if you do that in 100 people in the population, this is what you get. You get a spectrum from left to right, where the people on the left side have more green, so lower risk, and people on the right have more red, higher risk. And it looks, if you plot it in a population, it will look like a bell-shaped curve, this normal distribution. And then you can see in that bell-shaped curve, most people are in the middle. So most people in the population are gray or average risk. But you have about 20% of people on the far right of this curve that have high polygenic risk. And now we can measure it with a polygenic risk score. You also have about 20% of people on the far left side who are protected. These are the people who sometimes you see they smoke or have a high LDL, but they don't have a heart attack. They have a protection from heart disease. And now you can quantify that with a polygenic risk score. This is exactly how we report it to people. We tell someone this is the spectrum and this is where you fall on that spectrum. For example, this individual will fall on the 95th percentile of that spectrum. So that person will be in the red zone and will be high risk. Now, the data for this started from work from our group in 2018. This paper in Nature Genetics on the left side, this is the bell-shaped curve that you're seeing. And you can already draw cutoffs and say people above a certain threshold are a certain increased risk. These scores over time kept getting better and better. 2 years ago, we published an updated paper in Nature Medicine that shows the improvement in prediction. But basically, 20% of the population are at threefold increased risk. This is very high. To give you an idea, this is equivalent to having diabetes or smoking or having LDL cholesterol more than 190. That's how high the risk is in terms of magnitude, and it affects about 20% of the population. Now, the important thing about this is that this is based on your genetics. So it doesn't wait until someone develops blood pressure or accumulates smoking or develop obesity or high LDL. You can measure it from time of birth because you're born with your genetics. So these curves that you see here, these are strata of risk, and they separate when you start to have disease in the age around age 40 or 50. But before that, everyone is the same, but you can actually identify these journeys of people and when they're going to separate over the risk of their lifetime. Another important thing is that people with high polygenic risk and non-high polygenic risk will have the same LDL cholesterol. So you can't tell them out with another blood test with high cholesterol, unlike familial hypercholesterolemia, which you could already guess by measuring the LDL cholesterol, which is elevated. Now, is it additive to our existing clinical risk calculator? We heard about the updated PREVENT calculator, and the previous guidelines had the pooled cohort equations. The short answer is yes, it is additive to clinical risk. So the curve on the right side, it's a forest plot. It's looking at multiple risk factors, and polygenic risk score is right here at the bottom. And basically, polygenic risk score alone is the strongest individual risk factor compared to any other risk factor. But then if you add it to something like PREVENT or pooled cohort equation, it will increase the prediction of that calculation. Another thing that's important is that genetics is more important in younger people. So the best increase in predictive capacity of polygenic score is under the age of 55. So this is work from our group that I actually cited in the guidelines. We started with age 40 all the way to age 75 in 5-year intervals. In blue, you're seeing clinical risk, and in orange, you're seeing genetic risk, and green is combined. So you'll see that at younger ages, more people have higher genetic risk that is contributing to events. And as you go older, that orange almost disappears when you're 60 or 70 because people already have multiple clinical risk factors that genetics matters less. But in younger people, it matters more. Important thing to know is that DNA is not destiny. So if you have a high genetic risk, it doesn't mean that there's nothing you can do about it. There's a lot of things that you could do about it. And I will highlight two key papers. This one came from the New England Journal of Medicine from way back in 2016, and there's been multiple papers to illustrate since then. When you look at people with high genetic risk, I'm illustrating these 3 bars on the far right. If people have a healthy lifestyle versus if they have an unhealthy lifestyle, their risk was cut in half. So healthy lifestyle can attenuate or reduce a high genetic risk. So it doesn't mean that if someone has high genetic risk, they're doomed. They could exercise, they could eat healthy, and that could reduce their risk of heart disease. The other thing is lipid-lowering therapy, and this has been shown from analyses of clinical trials of multiple statins and PCSK9 inhibitors. And basically, individuals with high genetic risk derive disproportionately higher benefit from LDL lowering. So these people, if you lower their LDL, they'll even get more benefit from that LDL lowering than a general person that you lower their LDL. And this is illustrated in these plots here on the right side. So the gray one is statin versus placebo. The hazard ratio is 0.76 in a meta-analysis of clinical trials of statin. If you look specifically at the high genetic risk, the hazard ratio is 0.56. So disproportionate benefit, even bigger reduction in risk in people with high genetic risk. So the way we think about it is in younger age, 18 to 40, it's the only risk factor because there's nothing else. When you start getting into the middle age, 40 to 55, you can improve the precision and risk estimation by adding it to conventional risk factor. And then as you get into later age, it can guide secondary prevention and even after the onset of coronary artery disease. And we won't cover that data, but we have a lot of data in that component, but this talk is focused on primary prevention. Our group has started returning these scores in clinic back in 2020. This was actually the first report of how we return it in clinic. We have a website that's publicly available and explains what a polygenic score is, polygenicscores.org. And we've actually studied the implementation of what happens if you return this polygenic score to people in a clinic at Mass General. And then we determined that actually about half the people had a change in management and mostly revolved around intensifying lipid lowering or adding or initiating lipid lowering or performing some form of coronary imaging, which is something like a CAC score or a coronary CTA. And this has preceded the class 1 recommendation for CAC score in the current guidelines. This is published in 2022. The work was done from 2019 to 2021. One of the things that we were really passionate about is how do we get this into clinical trials? There's been paucity of clinical trials studying polygenic scores. We've written about the subject in 2022. And then in 2024, we launched the first series of clinical trials called the PROACT trials, which you're going to start hearing about in ACC and AHA in the coming few years. This is the first paper from PROACT that was published in JACC by our group 2 months ago. It's still in press. But basically, we report that what we did in this trial is we are getting people who are low risk on everything else. So these are people with a very low prevent, low LDL cholesterol. These are people that you would never start them on an LDL cholesterol lowering statin therapy. So the exact gap in the guidelines. But we know have high polygenic risk. And we are inviting them and doing a coronary CTA to see if there's any subclinical plaque. And the long story short is this is the punchline from that paper, where basically 1 in 2 people have subclinical coronary plaque. And when we look by age and sex, 3/4 of males, this is a mean age 55, had subclinical plaque on a coronary CTA. Even when you look in the 40 to 49 age group, 53% of males had plaque. This is an example of what that looks like. This is one of our patients in our study. He's actually a physician in our hospital, but he's a 46-year-old man who had no clinical risk factors, had a CAC score of 0, and had a very high coronary artery disease polygenic risk score. And this is what his coronary CT showed. He had a mid-LAD plaque that was 40 to 50%, that was non-calcified. And this is the interesting thing about young people with high genetic risk. Most of the plaque is actually non-calcified. So CAC score alone wouldn't actually catch them. We don't believe that polygenic score should sit in isolation. One of the things that we really think about is the concept of a multi-biomarker panel. We're already measuring LDL cholesterol, you're measuring CRP, you're measuring lipoprotein A. You heard a lot about it from Dr. Arnaout and Dr. Biz. This is quite important. So one of the concepts that we're putting together, this was another paper in JACC that we put together last month that actually talked about this idea of measuring all 4 biomarkers early on in life. And we looked at, so this is CRP, LDL, LPA, and CAD PRS. And we looked at 250,000 people where they had this measured across age and sex and followed for 13 years. And what we found is that the prediction is very high in younger age groups. So starting with people 40 to 50, for people who have multiple biomarker elevation, the risk is so high and definitely justifies LDL lowering. And we're doing more trials on this framework of measuring these 4 biomarkers early in life and then initiating lipid-lowering therapy if they're elevated. This is what a report today looks like. This is what I give to my patients in clinic. We focus a lot on coronary artery disease, but we can calculate these scores for a variety of genetically driven diseases. So this one is a cardiovascular panel for atrial fibrillation, coronary disease, diabetes, lipoprotein A, hypercholesterolemia. And it gives us what is high and what's not high. In this particular patient, their thoracic aortic aneurysm risk was high. Now, it's not all rosy picture. There's still a lot of challenges in the field. I'll just keep this brief to say one of the biggest challenges is that we think about is calibration of these scores in different ancestries, because people of different ancestries, like Arabs or African ancestry or South Asian, have different genetic makeup. So the scores have to be optimized for these ancestries. And today, a lot of the scores are coming out of individuals of European descent, which has kind of introduced a little bit of a problem in the field. So one of the things that my group has done is really think a lot about Arabs specifically, and then optimize these scores in Arabs. So this is a paper that from 2023 where we've created new scores for Arabs that have actually exceeded the performance in European. And these scores are highly personalized to individuals of Arab descent based on genetic makeup. We're seeing a lot of adoption starting to happen in the Arab world. The Abu Dhabi Department of Health issued new guidelines last year on the use of polygenic scores. That's very positive and advocating for their use. Same thing with the Saudi Heart Association. I gave a talk a few months ago, and there's work ongoing on a scientific statement by the Saudi Heart Association to adopt polygenic score. Where are people getting their scores now today? It's still very limited, even in the US and Canada and the UK. In the US, there's really 4 or 5 companies actually offering it: Allelica, Myome, Genomic MD, and some hospitals are starting to offer it, like my hospital. In the UK, the biggest company is called Genomics PLC, and now it's rebranded as Genomics. They offer also the score. And then in the GCC countries, Saudi Arabia, UAE, Qatar, and hopefully soon in Lebanon's new company called Abijanna that I had the privilege of launching based on the work from our research lab at Harvard. I want to wrap up. I don't want to, keep this on time, but this work is really that I summarize is over the past 10 years from a large group of people from my lab and collaborating labs, in our organization. And the hope is that in the next iteration of the guidelines, we'll see similar to what happened with the journey of CAC scores. It took about 15 years for this to become a class 1, in the guideline, even though many people practice this and knew it. We believe that polygenic scores is going to follow the same trajectory. Guidelines will always be a little bit behind on where the evidence is moving, but we think that's a start of being at least present in the guideline as a risk enhancer, and then eventually moving into specific class recommendations.
Thank you very much for this exceptional presentation about quite interesting topic, and maybe the future would be here in classifying our patients. I would start with a quite practical question. How you see this would be how we can get the most of it about cost effectiveness for this. Is this to launch it on population-based campaign to do genetics for example, for some areas, or you think to more targeted for relatives, for patients that present for ACS, for example, and all your data at about the population of more than 40, and here in Lebanon we see lots of patients presenting with ACS before 40 by the definition of MI of young patients. How you see this in practice? Thank you.
It's a great question. A few quick things. I think the data in Lebanon is not unique, right? Like in the US, recent paper, 4.5 million MIs, 60% of them not on any preventive therapy. MI is the first presentation, which is sad. This is why something like genetics should be measured earlier. You're right, most of the data is on people of age 40 and onward, but it's a first risk factor. It doesn't change before the age 40. So the same information you get on someone at age 40, you can get it at age 20, at age 10, or even when they're born. So I do think there's enough data to support testing on younger people. The part on the question on the cost effectiveness analysis is quite important. Overall, this test has the potential to become very cheap because you measure someone's genome once, and eventually you can get a lot of information from it. So for example, if you look at the CAD PRS alone, it's going to feel expensive because you have to read all someone's genome and then calculate that score. But it's the same genome that you can read for example, I've showed you the report that we have, which is 10 specific conditions. And then now you can add on it cancer and autoimmune diseases. So the cost is really upfront with the genome sequencing, which has become quite cheap, and then additional cost becomes very small when you add other, other utilities for it. So I think as increased adoption is going to happen, the cost is going to become cheaper and cheaper.
Dr. Fahad, this is great. Marwan Rifat here. This is great presentation as usual. I want to ask you if some of my colleagues want to order the polygenic risk via Avicenna for Lebanese patients, what's the estimated cost?
I don't know. I don't know right off the bat. Again, with the company, there's multiple, basically multiple packages, depending if you're ordering it for a single trait or multiple trait, and if it's ordered as a single test or with a preventive package where people are meeting with a genetic counselor. And I think this model overall is still to be determined. For example, should you have a genetic counselor every time you have a polygenic risk score? For example, I know my one, for example, for your practice, you probably don't need a genetic counselor because you'll talk to the patient, you know exactly what it is. But it's challenging to explain it by a cardiologist who might not be familiar in genetics. And I think even in the US, this field is moving really fast. I think we're seeing so far, a lot of the implementation has happened with a paired genetic counselor that will get that result. But I know this model is not going to be cost effective at scale. For example, Avicenna as a company in the Middle East is now having the model where physicians order the test and actually pay upfront, but then the company takes over the communication with the patient, including genetic counseling. So it's not additional work on the physician. But also there's ongoing conversation with governments at the public health level with Saudi Arabia and UAE to deploy this at scale, which means we're talking hundreds of thousands of millions of people being tested for this score and then being returned at scale and obviously paid for by the government system.
One question here. This is Emil. It's first, thank you for being with us at 4 a.m. your time. This was fascinating as usual. I can maybe later answer Marwan because I had the chance. I'm interested myself. I know my risk score. If you look at the regular parameters, I never smoked. I don't have diabetes, and my recent LDL became 133. This is the highest I've ever been, and now what? I'm 42. So I had the discussion recently, and I can give you more insights. But maybe you can tell, smiling, you can tell us because people sometimes ask, what sample do you need, and what type of, how does it get to you? Maybe if you can just shed light on the simplicity of the test to the people here.
Yeah, this is important. I mean, it's a quick, easy test. So you need DNA. DNA, you can get it from any saliva, mouth swab, or blood test. So in most cases, the way this is done is a saliva collection kit. So literally a plastic tube that you spit in it. And in the US, it does not need to be refrigerated. It can last for several days. So people spit in a plastic cup basically and ship it. So that's how easy this is. And then there's also collection with mouth swab. Literally, you just swab the cheek and then ship it. It's at room temperature, and usually it takes 2 to 3 weeks, and it will come back as a result, like the report that I showed.
Dr. Akl, excellent presentation. Just I want to ask you one thing. Do you think that this test is going to be as a risk modifier, or you can advance it further? And if you see it in a patient with very high risk, then you did everything you do. What this test is going to modify your measurement later on?
Yeah, that's a great question. So 2 questions. The first part, the risk enhancer, no, I don't think it should be only a risk enhancer. I mean, obviously from our data, I think it's a very strong risk factor. It is really the strongest risk factor, and it's in 20% of people. So I think risk enhancer is a way of the guideline to slowly getting comfortable with things. For example, calcium score followed the same journey. There was a lot of evidence, and they didn't put calcium score in the guidelines up until the current guidelines in 2026, but we lost like 10 years that could have been advanced more. We knew that calcium score is very powerful in predicting risk. And I think with polygenic score, the same thing. It's going to take some time, but the evidence is way, way, way more than what's actually in the guideline as a risk enhancer. As I've shown, I mean, just to give an idea, it's equivalent to diabetes. It's equivalent from an effect size. And this is crazy. Like, it's really, really high risk. Now, the second part of your question is very important. Who do you do it on? If you have a patient where you already lowered everything, what else are you going to do? You're right. It doesn't add much, right? Like if someone already has an high LP and high LDL, and you've lowered the LDL to under 55, and they've exercised, and maybe you've put them on some low dose colchicine, you've done the max. There's nothing else to do. I agree. Then it wouldn't add. It wouldn't add a prediction. It's interesting because we're seeing a lot of people wanting to get it after they have an event. So, your patients are coming in with an unexplained early MI and they want an explanation. So I end up actually testing it a lot in this population. But you're right, it doesn't do much in that population. You can be more aggressive. I bring the LDL to 30 and I add the PCSK9 earlier on top of a statin. And sometimes I do use low dose colchicine. But that's it, right? You're gonna go lower. I would say most of the time it ends up being lower LDL for longer, like the last slide from your talk, right? Lower, longer, the better in most people. That's the biggest intervention that we see. The issue with that we're trying to advance with PROACT is we're missing a huge group of the population that we don't treat. So, for example, if you look at the prevent distribution in the population, so prevent will tell us under 5% is borderline risk, under 3% you absolutely didn't treat. But if you look at everyone in the population under age of 50, 97% of them or have a prevent under 3% by design because it's driven by age. So imagine all the people that you guys see with MI and calcium on CT under 50, all these people, there's 97% of them, their prevent is under 3%. So they would never get a statin with the guideline unless you start measuring LPA and PRS essentially to try to see these risk factors and then follow a biomarker-based model.
But one last question. So can you do multiple sample in one kit? Or it's different?
Multiple sample from the same person or different people, you mean?
Different people.
No, it's a single sample because it's a saliva. Yeah, it's a simple one kit per person. So it's a saliva kit, so they'll spit in it and then they'll send it to the lab and it extracts their DNA. Now, what you could do is once you have someone's DNA, then you can get any score in any monogenic and any polygenic for any disease, cardiovascular disease, cancer, and this is the power of it. Versus, if you're measuring LPA, you pay for LPA, you measure CRP, you pay for CRP. Here you pay for the genome. And then every time you have an add-on test on that same background.
I'll thank you, George. Thanks very much. Congratulations for you and your team. Looking forward to see you in Beirut, and we are proud of you. Thank you.
Thank you so much. Thank you so much. I would have loved to be in Faraya instead of here.
Thank you very much. Maybe we can close the session. We'll close the talk here and we'll proceed